Okay, so I present a case of a man, 44-year-old. He's a boxer that presents us with light perception for a cataract intumescent post-traumatic with retinal detachment secondary to giant retinal tear. Obviously, we couldn't see the view of fundus, so we diagnosed the retinal detachment with the use of ultrasound test, and we went straight to the surgery, planning a cataract surgery combined with a vitrectomy. The cataract was quite dense, and we made the implantation by IOL. And after we went for a vitrectomy, and we found a very, very huge retinal tear, and with a retinal detachment, and the flap was reversed. So we did some maneuvers in order to reverse again the flap and the retina, and to put the retina in the right position with the use of the forceps. And then obviously we use the PFSL in order to unfold the retina, and we fill the vitreous cavity with the PFCL, and after, with the use of a chandelier, we did a double maneuver with two hands, and for the accurate shaving of the base, and for removal the anterior retinal tear flap. At the end of surgery, we did laser posterior and across the corner of the retinal giant tear, and for 360 degree. And finally, we skipped to direct PFCL silicone oil exchange. And finally, we did also a iridectomy inferiorly, because there was a traumatic case, in order to prevent any passing of the silicone oil into the anterior chamber. 1 week later, we had a good retinal situation, and 2 months later, the vision was 0.4 logmar with retina completely flat and laser scars nicely. So, which are take-home message? Parsonalitectomy is the gold standard for our case for retinal detachment in giant retinal tear. Can be associated with scleral bucket or not. It depends on the case. Obviously, the silicone oil PFCL is the helpful tool in order to avoid the slippage of retina under the exchange, and this is the.
Thank you very much. Very well managed case. It was a very nice demonstration of, giant retinal break, retinal detachment management associated with a very advanced cataract. So maybe I can ask, while you're getting prepared for your questions, why did you prefer to do the direct perfluorocarbon silicone oil exchange? What are the advantages and disadvantages for this technique? Because I think you were afraid of having slippage, and maybe in giant retinal breaks we have that problem. So what's your point?
Actually prefer the technique of direct PFCL silicone oil. And what I do, generally I fill a PFCL, I fill the vitreous cavity with PFCL. And before the exchange, I make sure that the vitreous is completely, and I push the PFCL, inject PFCL, and I make sure that PFCLs get out from the sclerotomy in order to be sure that all is PFCL. Then, to make sure again that there is not slippage during this during the exchange, I go with the Charles just over the retinal break, over the retinal tear, in order to extrude any possible fluid, any possible liquid that is inside. This is my choice. I prefer from the air exchange or other.
Do you use passive extraction or active extraction by fluid cannula?
Actually, passive.
Passive, yeah.
Passive.
Otherwise, yeah.
Maybe it's slowly. Maybe it's
Difficult
better for the
to organize.
pressure.
So
I prefer.
Why don't you do the air fluid exchange, for example, before
Because
instead?
Because the problem is if we could do, but it's quite harder because the problem is that if we go with the fluid exchange on the line of on the border of the retinal giant tear, you risk that there is a slippage, and I don't like so
Okay,
so
thank
much.
you.
Can I have one question here? So, in this case, you put the intraocular lens in the back, yes?
Yes.
And what's the logic of doing peripheral iridectomy? There's a posterior capsule is behind it.
Because the cap. Sorry.
You did the inferior peripheral iridectomy.
Yes.
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 Why?
Because I'm sure that the LL is in the bag. I put the LL in the bag. Yes. And I'm quite sure that it was stable in the bag, and then I check again.
The question is
Just
why,
as a precaution, I guess. Yeah, probably.
but if
we
there
may
is
not need it.
But if there is a posterior capsule is there,
Yeah, you
iridectomy
may
is
not
not going
need
to
it.
work. It has no logic. So next,
Okay.
anyone has questions?
Ahmet has.
Yeah, just very quick comment. Beautiful surgery. Thank you so much.
Thank you.
Just a reminder that also gas tamponade can be used in giant retinal break, especially the ones with good visual potential. And I think Noor in the EVRS, Noura Kar is going to present the data about giant retinal tears and how detachments and how they are managed. Because I've seen like several cases managed by oil, but just again for the audience, there's also gas which is actually used when there's good visual potential. But thank you so much for showing your technique. It's so
Yes,
beautiful.
it's possible. The gas
Yes,
as well.
so beautiful.
Thank you.
Thank you. Thank you for a very nice presentation. The next talk will be by Abdullah Al-Kahtani. Is he here? I don't see him, but...
So we move to the
So
next
we
one.
move to the next one. Carla Perez.